And now our first speaker, Dr. Tammy Duong, is a director of the UCSF Geriatric Psychiatry Fellowship, associate clinical professor, vice chair of medical education, and the Ambulatory Executive Medical Director in Adult Behavioral Health. Her clinical practice focuses on older adults with psychiatric manifestations of neurodegenerative disease, delirium, and late life mood and anxiety disorders. She completed her adult psychiatry residency at the University of Southern California and Geriatric Psychiatry Fellowship at UCSF. Her interests include geriatric psychiatry, neurodegenerative disorders, ethics, medical, education, diversity, equity, and inclusion. We are grateful to have her join us. Dr. Tammy Duong.
Thank you so much, Alan. I'm going to stand to the side of the podium because I'm a shorty cakes and you can't see me if I stand at the podium. So I have a lot of slides and I've been told I'm a chatty Cathy, so I will do my best to keep us on time today. So this talk is called Aging Minds Matter, and I think I'm supposed to remind everyone that these are my own opinions. I'm here kind of on my own, not necessarily representing the University of California. So today, and I have no disclosures, nobody pays me enough money for that. So really today, I hope to talk to everyone a little bit about kind of what do mental health presentations look like in older adults. That could go on and on and on and on for many days. It would take you a whole year to learn everything. That's why we have fellowships. And then I'll talk a little bit about what are some of the barriers that I see that our older adults face in actually accessing mental health care. And then we'll talk a little bit, I like to try to leave us all with a little bit of hope for the future and talk about, okay, let's talk about what we can do. What's the next steps here? So I'll start us off with a quote. And I get this like referral message almost every single day of my life. And you notice I had a lot of titles. And so this question comes up all the time. I've got a patient with a pressing need, urgent, and we need a geriatric psychiatrist. I need someone to see very soon. Can you please help? And here I am at UCSF, this wonderful medical school. And how many geriatric psychiatrists do we have on faculty? I can count them on one hand, right? I mean, there's about 4 of us. One is more or less retired and he throws me a bone and he hangs out, which leaves 3 or 4 left of us. So there's just not enough people to do all the needs that we have. So let's talk about part 1, the need for geriatric psychiatry. So we have the saying, why is there a tsunami here? We have this saying in geriatric psychiatry that get ready for the silver tsunami, or 0 hour is another thing that it's called. And what this is that's when the baby boomers turn 65, right? Our most populous generation, when they go into older adulthood, and we're going to have a lot more older adults, a lot more people to serve. We heard some statistics earlier. I've got some more here. These might be a couple of years out of date and maybe more than this. But, by 2030, just what is now 2025, in 5 years, we'll have more than 73.5 million older adults in the United States. We'll have 83.7 million by the year 2050. This is a lot of people. There's more patients than I can see myself, right? Than the 4 people on my faculty then can see. And another thing is I wanted to point out is that in this population, among all these people, we're going to have a lot more women, a lot more kind of underrepresented people in this age group. So we also not only just need more geriatric psychiatrists, we need to diversify too and actually serve and match the people that we're trying to serve, right? So I've got some statistics here. And so you can kind of see these minoritized populations, they're growing, right? We're not getting smaller, we're growing. So we've got this increasing demand. And we know out of all those people, who's going to need mental health care? So we know about 20%, about a fifth of that population of older adults is going to need some kind of mental health need, right? And what are the things that we're going to be looking at? We're going to be looking at, comorbid neurodegenerative disorders. We're going to be seeing people who are just doesn't have dementia, but have some kind of cognitive impairment. People who are just generally kind of more frail as they age. These are the people who need help the most, right? Minoritized aging adults, right? they're more vulnerable, and they're more vulnerable for a lot of reasons, right? There's a lot of minoritized stress there. It's a lot more difficult to actually access services and needs, and having them kind of help navigate through the healthcare system, right? And just kind of like the system at large for all these other services we're going to hear about today, right? And I keep emphasizing this point because everyone reaches out to me. If we're going by the way we're going, the ratio of geriatric psychiatrists to patients is going to go from 1 to every 23,000. I can't imagine having 23,000 patients on my panel, let alone this is going to go to 1 geriatric psychiatrist for every 27,000. And I could work every day, 14 hours a day, and never meet this demand. Right? So, so what this leaves us with? This leaves us with the unmet needs of older adults, right? And what does that get us in return? Not meeting the needs. Well, we know that we're just going to have, in general, less well-being, right? There's more loneliness and social isolation. And so you're going to hear me talk throughout this talk the themes of loneliness and social isolation. And when I say loneliness and social isolation, they're actually two slightly different definitions. So social isolation is not having kind of people around you, right? And then loneliness is maybe you have the people around us, but you don't quite connect. So you can kind of see how they're overlapping. They're not exactly the same thing. But we do know those two factors go into a lot of other things, right? So if you are suffering from loneliness and social isolation, we know you have worse quality of life. These people tend to have just kind of worse health status overall, right? Which leads to greater disability, increased morbidity, mortality. And once you have all of those things, that puts a higher cost on society as a whole, right? That we just need more and more resources. And you have to be able to take care of everyone, right? So all of these things are just interconnected along the way. Right, so I have painted such a sad picture for everyone. I'm so sorry. But so that's kind of the need. And then when it comes into my office, what does this look like when this comes to me, right? So this is just kind of the tip of the iceberg. So we'll talk a little bit about common geriatric syndromes. And this is, again, just real fast. I'm going to run through these things. This is just high overview of things. I could go, like I said, 10 hours into each one of these topics. So we'll open it up for questions later. But the most common things that I see, one of them is depression. And so when I talk about geriatric depression, depression's just, it's not common. It's not only common to older adults. It's common to, right, everyone and all adults. And so when I say geriatric depression, I think of two broad groups. They're the people who had depression when they were younger, and now they've aged into older adulthood, right? You're older, now you have depression. And then there's the other group, which is new onset depression. They've never had depression in their lives, and something has happened to them. There's a big life stressor, something's happened, and now they have depression. And why this matters, I tell my fellows all the time, is because, the prognosis is a little bit different. The treatment might be the kind of the same, but one tends to do a little bit better than the other group of it. And so it's important to keep that in mind, right? And because it helps direct our treatment. Depression is very costly, right? If you think about depression and what it does to us and some of the symptoms, we just don't feel well. We can't get up. We're just laying around all day, right? So we get more deconditioned. We get more frail. So this actually costs us like billions. Yeah, I had to double check that number of that's billion with a B, $43 billion annually. That's a huge chunk of money, right? And not all the seniors who have depression are coming to see me. And actually, a lot of these patients are being treated by their primary care providers. One of the things that I do is I am integrated into a primary care practice to try to help them out a little bit and try to take some of that pressure off of them. But I will say geriatrician medicine doctors are wonderful. I can't sing their praises enough because they're really good with treating geriatric depression and all the complex comorbidities that go along with it. And they're usually they're not afraid of older adults with depression. So I thank them a lot because I couldn't do this job without them. But if you don't have a geriatric psychiatrist in your office, and it's not common to have a geriatric psychiatrist in your primary care office, what commonly happens is that these patients get undertreated or not treated or misdiagnosed in the reality of it, because a third of these patients are going to be treated with sleeping medications, not antidepressants, right? And then maybe a third of them are being treated with antidepressants, but they know how to start a medication, but they don't know how to titrate it. They don't know to get to a therapeutic dose. They also may not know, what do I do if I use one medication and it doesn't work, right? These things can get complicated fairly fast. And we're not always doing our best job of, equipping our colleagues in primary care to treat the need as well. All right, so what does it look like, right? I've said this is, and I may go to the top of the slide and then kind of go to the next slide. I realize I repeated some things, but who's most at risk for depression when you're older, right? So what we often see is you've got maybe someone who is doing just fine in life, but all of a sudden they're facing multiple losses. One really common thing that I hear is, well, everyone around me is dying. I've got no one else left. My oldest patient, she was 105, recently passed away, and she would say to me all the time, kind of this passive thoughts of death, like, yeah, I'm ready to die. It's fine if I die. And why is that? Well, I've done everything, and I have literally outlived everyone else. And you kind of have to go like, yeah, it's common, but also not okay. That's the other thing that happens with older adults. They go, well, aren't I supposed to be depressed? And I say to them, yes, it's common, but it's still not okay. We should still do our best to help you out, right? Then you come with the older adult who, was really active in their younger days, really independent, and, they're having some kind of loss in their health, bodily function. They're just not mobile, agile, or able to do what they used to be able to do when they were younger. And that's really hard too. If you're really independent, all of a sudden you can't do the things that you're used to doing. That's hard, right? So that's a vulnerable group of people, right? And then cognitive decline, which is really tough because for some older adults, there's that period of time where you're fine and you kind of know something is going on and something isn't right. And that's really, really scary, right? Not everyone has that insight, but some people do, right? And they get a lot of anxiety, depression as a result of it. And then there are a ton of other setbacks. Like I said, social isolation coming up again, loneliness, right? Financial is a big thing. So I also have some patients who come to me and say, doc, I wasn't planning on living this long. Now I'm worried about these finances. And because I hadn't actually planned on living this long, what am I going to do? I actually had someone who said, my gosh, I'm really worried about Social Security because that's my income. What am I going to do? Right? So these are real worries that come up. I'll skip this bottom part because it bleeds into the next part. Is that so this statistic is a little misleading, and I use it to trick my fellows when I'm teaching with them because 4% of community dwelling older adults have major depression, and that doesn't sound like a lot, but if you think about it, who are those community dwelling older adults? Sometimes it's the people who are really healthy, doing well, independent, right? So it's a little bit of a skewed statistic. And if you kind of jump down to that bottom bullet point, if you look at geriatric psychiatry units, the majority of patients who are being admitted actually have major depression. So it kind of depends where you go. If you go to an inpatient unit, you go to an inpatient hospital unit, a lot of those patients have depression. If you go to a skilled nursing home, almost 50% of those patients have depression. So it's all about the population that you survey too, right? Statistics can be misleading. But we also know depression is just very common lifetime. So 20% lifetime prevalence of major depression throughout the whole population. So that means 1, 2, 3, 4, 5, right? And 1 out of every 5 people would have a diagnosis of major depression. So it's very common, right? So this statistic too is common as well in younger adults and older adults, that the ratio of women to men. So women, it's a ratio of about 2 to 3 to 1. So women are more likely to develop depression than men, right? And I've already talked about these last couple of statistics that, if you're in a nursing home, you're ill, all of those things, higher risk of depression. So what does it look like? What does it actually look like for an older adult? And how can you start to spot it. I don't the ask isn't for everyone to be able to diagnose depression here. That's an outrageous ask of me, but like generally know kind of what it starts to look like, right? And as you'll notice, as I go through this talk, depression can look like other things too, right? So common symptoms in older adults. A lot of times the first thing people come in to say, they'll talk to your primary care doc, is they're having problems with sleep, which is it doesn't mean you have depression, but it's really common for older adults to have problems in sleep. You might hear things like, they're just not hungry as much anymore. They've got a lot of aches and pains. But you know what? A lot of medical illnesses have these same symptoms, right? And so it's like when you have a hammer, all you see is nails. I think that's a thing I hear all the time. So my residents who are psychiatrists and my fellows who are geriatric psychiatrists, I try to warn them all the time. You've got those symptoms, but could it be something else too? You always have to, when you're a geriatric psychiatrist, I like to think of myself as you're part family doctor, you're part rheumatologist, you're part psychiatrist. You've got to be aware of all the things that are happening, right? And then the other symptoms that tell me like, aha, maybe there's a little bit more depression, is you might hear other things, right? Not enjoying life or activities as much, not as excited to do things as much. And you may hear a lot of synonyms for depression, because older adults may not say the word depression. They may not say that they are depressed. They may say they are sad, they are blue, they are feeling down, they're just not with it, they're just not themselves. So I've got to be really attuned to ask the same question in 4 different ways, 5 different ways sometimes, to get the information. Because I think the older adults who are coming through now have a little bit more of a vocabulary for it than a generation ago when I used to see that population. So it's starting to change. Awareness is starting to change, but still, it still hasn't been as talked about, 40 years ago as it is now, right? And then some people may have other kind of more severe symptoms, like feeling hopeless, guilty, thinking about death. I mean, I have older adults too who just commonly say, yeah, I'm thinking about death. And, and in some degree it is normal when you're older to be thinking about death, because it is, mortality and you need to prepare, right? But there is a line that gets crossed when I'm thinking about death and versus I want to die. I'm going to do something to hurt myself, right? There's a really fine distinction there that I teach my trainees all the time to try to pick up on that distinction. And in some cases, and this often gets missed in older adults, that in really severe episodes of depression, people can get really psychotic. And that can be kind of subtle sometimes. So what I call psychotic guilt. It's this thought that, nobody cares about me, nobody loves me, I'm going to be in financial ruin. Or it could be, I had a patient one time, she was convinced that she had cancer. Tall woman, thin, and you kind of go, well, do you have cancer? Maybe you do. $1 million workup, it's no cancer, but she couldn't be convinced. And then I remember trying to start a medication with her, and that nice little question, which medication do you want, this one or that one, just kind of pushed her over the edge. And there's no convinced that like, if I'm here, I'm going to be in financial ruin. And I talked to the husband and he's like, we have lots of money. We have insurance. This is not true at all. And I realized, oh, you're really psychotic right now. Oh, okay. And sometimes people think it's anxiety. And because they're really, really worried about something. Like this woman was really, really worried about cancer, even though she couldn't be convinced otherwise. And there's that really fine line, that fine distinction sometimes where it just didn't make sense, right? And like I mentioned before, so what you might see less common in older adults, you actually might see, so when you're younger, we tend to see a lot more like low self-esteem and guilt. I know I just went on this rambling rampage on psychotic guilt, but kind of just guilt in general is a little bit less than older adults. Because the great thing I really enjoy about older adults is they've learned throughout time to kind of build up that sense of self-esteem, and some resilience. And so I always find that like that's really, really lovely. So we see less of that. But what I see more of, and I mentioned this before, is a lot more of those physical complaints. Those just seem to get amplified. I mean, if you think about it, if you already had those symptoms and now you were depressed, those symptoms just get worse, right? So headaches, fatigue, dizziness, cognitive complaints, all of those things can get worse with depression. And sometimes that's just what people come in, to say is what's wrong with them in the first place when they see the doctor. And then in some cases, what I see is kind of things like, and this is things like food refusal. So this is in my very frail patients. Sometimes they're very sick as well. Sometimes they have some cognitive impairment where they just get so passive. They just kind of passively, slowly decline. And it's almost kind of like a failure to thrive, where they're just not eating. They're just neglecting their hygiene. One of my favorite patients, like favorite patients, I remember whenever she would get depressed, she would stop cooking. And she would just kind of do like heated meals, in the microwave, canned food, just like really easy food. And I remember the first time I met her, I went, does she have dementia? Like, she seems a little cognitively impaired. And we treated her, she got better, and like, whoop, that cognition just bounced right back, right? And then she got depressed again some other time, and then again, it looked like she got a little cognitively impaired. And so when we see those symptoms, we call it pseudo-dementia, which I'll talk a little bit about later. So there's a risk factor if you have kind of depression is a risk factor for cognitive impairment and depression. And then cognitive impairment and depression is also a risk factor for depression. So we know there's this bi-directional relationship here. So we do worry about depression for a lot of reasons, for your health, but also kind of to keep your brain healthy, right? So I've talked about the risk factors for depression, but when you have depression, what is this a risk factor for? I already talked about kind of the Alzheimer's disease, dementia, kind of the dementing illness. But as we know, it's a risk factor for completed suicide as well. We know older adults, when they do attempt suicide, they sometimes pick the most lethal means, right? Like really violent means. And so they actually have a greater, I don't remember the statistics, so don't ask me the statistic later, but it's a greater risk of completed suicides versus when you're younger and, and maybe you survive. So it's a lot more lethal for older adults, right? And also, we know that for depression, there's this kind of bi-directionality for other diseases like cardiovascular disease, right? And so I think depression, I had in some other slide deck, I think it's like cardiovascular disease has like one of the highest morbidity mortalities in older adults, and depression is like number 4, I think. So, it's just a risk factor in general for disability. What are some of those poor prognostic factors for an older adult with depression? So I mentioned chronicity, and that's the difference, right, with someone who maybe had depression and now they are older and they've had depression for a longer time versus someone who's now older and they're now developing depression, right? And so the longer you've had it, the worse your prognosis is. So a lot of times there is some urgency in treating depression for that first time, right? If you have other comorbid illnesses, other things going on, poor social supports, functional limitations, all of those are poor prognosticators. All right. I'm gonna speed myself up here because I realize I got like 15 minutes. I got a lot of talk to go. So I'll keep going. Let's talk about anxiety for a second, right? One of my patients told me one time, she's in my office, she's like, "Doctor, aging is not for wimps." And I was like, that is correct, isn't it? And so anxiety is kind of, it gets better and worse when you're older. In terms of, younger people, the most common anxiety disorders are things like phobias, like specific phobias like fear of flying, fear of spiders, right, and panic attacks, where that's not as common. I mean, some of that's common in older adults, but what you get is like more of this kind of unspecified anxiety. So it doesn't fit neatly into the diagnostic categories, but we do have a lot of worry for older adults, right? And, what happens when people worry? They start to avoid things that are worrying them, right? So if you think about an older adult, if now they're worried about like falls and going out into the world, well, their world just started to shrink a little bit, right? And a little bit more and a little bit more, a little bit more, because now they're just avoiding lots of things, which is not great. It's a risk factor for, more anxiety, depression, things like that. And so, when we think about worry, I mean, there are some adaptive things to worry, right? If you think about it, there's, this curve of like, you need a little bit of worry to get things done, but too much and you just kind of crumble, right? And so we think of worry as kind of the short-term response to something kind of uncertain. It kind of is a call to action. It like fuels this belief that, hey, we can control what's going to happen. But you worry too much. And, one of my supervisors used to say, well, don't waste a perfectly good worry. And I was like, yeah, that's about right. And what she meant with that is some things, you worry about things, but some things actually aren't in your control. And so sometimes worry is a choice. You can actually decide what you worry about, right? And that's a little bit of the treatment of retraining yourself. But for older adults, the common things that I hear that they worry about is finances, their health, their family's health, right? One of my patients this week she sat in my office and she was just so worried about her son who was having surgery, not her own health. She was doing great. For once, I'm going to knock on wood because I don't want anything bad to happen to her, right? But we just sat here kind of talked about her family and how she's worried about her family the whole time, right? So anxiety disorders, whoops. Yeah, here we go. So what's less common in older adults is kind of like I said, those phobias, those panics, and those kind of what we call like generalized anxiety. But what becomes more common is kind of that non-specific anxiety that doesn't fit into a neat diagnostic category. And anxiety symptoms are common. 20% of older adults experience anxiety and worry at some point, right? Which is a lot, which again, it's 1 in 5. And I mentioned this before, how anxiety can be a little bit protective, but also too, when you're older, that can be a little bit protective for anxiety. Because what I really like about older adults is that they've seen stuff before, right? Like they know how to handle themselves. They've learned this is what works for me. These are the tools I've got. And so I'm going to use those, right? And they already have this great set of coping strategies. I love that. It makes my life easier, right? I'm like, ooh, less work for me. Let's just like build on those skills, right? So I actually have a lot of fun with this age group. But so I'll just kind of quickly go through, what does this look like for some of these common disorders? And so for this generalized anxiety disorder category, what you'll hear from people say is they worry about everything. Like you ask them, what are you worried about? And they're just listing off everything: finances, being awake, what are you going to wear, what are you going to eat, right? I mean, and it's just like, it's hard for them to stop. And I'll ask them, can you focus your attention on something else? I'm like, nope, so worried. Can't do anything about it. And this worry bleeds into, and this is very common, that their mind is just going all the time. They can't fall asleep. So you'll commonly hear about like, I'm having trouble sleeping. Sometimes you hear like if they're so keyed up, they get really irritable and snappish, right? They're just snapping at everyone. And maybe they weren't all that snappish before. And they're just kind of feeling on edge. And what often happens is why they're seeing their primary care doctor is because they're so tense, right? There's like, I had a patient, I'm like, your shoulders are up here, my dear. Lower these shoulders down. They have so much muscle tension, right? Which can cause like headaches, and jaw pain, and fatigue, and stomach aches. So you can get all these hosts of physical symptoms too. And sometimes they don't even know that they have anxiety. You kind of almost have to go through the whole thing and go, could it be that you're also worried? And then, you kind of get this look like, yes, yes, I am very worried. So people don't even realize. Whereas panic attacks, patients definitely know when they're having a panic attack. And these are the people I get that phone call into my office of like, I am having like sweats and chest tightness, and I think I'm having a heart attack. And a lot of these patients will go to the ER with these symptoms, and it's no heart attack. EKG is fine, right? And what this turns into just this like worry that they're going to have more panic attacks, and they just feel like they're losing control. And sometimes they just kind of feel like they're just not in their bodies anymore. Like they're just kind of not with it. And for the typical panic attack, it'll happen quickly, and then it'll last for a while, and it'll go down. And what we think is happening is what you can't really see in that kind of circle is that a lot of times that panic attacks they start with some kind of internal, some kind of physiological change, and then the worry happens, right? And then it's like a feedback loop, and then it triggers more symptoms, right? And which causes fear because it's uncomfortable. And so you're almost kind of stuck in this loop. And so what ends up happening is people think that they need to go find the trigger. Something triggered this panic attack, this anxiety. And sometimes the tricky thing is, sometimes panic attacks are triggered. but sometimes they're not triggered. Sometimes it's something internally physiologically that's happening. And what happens is they misattribute some kind of external stimuli to that panic attack trigger. And so they'll go, well, sitting here in this room with all these people caused that panic attack, so I'm going to avoid all people, right? So then that kind of goes into avoidance. And again, their world gets smaller and smaller and smaller. All right. So common medical conditions of what anxiety looks like. I mean, it could look like a heart attack, right? That's really common. It could look like an arrhythmia. It could look like someone's hyperthyroid. And so what I'm doing as a doctor is I'm also going through all these things to make sure people don't have the things on this list, right? And so again, it's like when you have a hammer, all you see is nails. And I'm trying to tell my psychiatry residents, you got more than just a hammer. Use all the tools in the toolbox, right? We don't want to miss some of these other things that are really serious, like a pulmonary embolism is very serious. We don't want to miss that, which is why I think, maybe if I have time, I'll go into this later, why sometimes it's challenging to be a geriatric psychiatrist, because you got to know a lot of medicine too. And I think people get a little bit scared off from that. Okay, I want to keep going. Let's talk about the brain, right? And let's talk about cognition. And what you need to know about the brain, and I won't dwell on this slide too much because it can get kind of complicated, is that, your brain has all these different parts of it and helps you do a lot of different things, right? It helps you make decisions. Your brain helps you remember things. It helps you actually, solve problems and keep your manners in check. It helps you talk. It helps you actually know where you are physically, and it also kind of helps you, relate to other people. And if any of these areas get damaged, right, then we have deficits. And so what we call, so the broad term is cognitive impairment. And dementia, what happens is you have one or more impairments in one of these things, right? And this is a change from baseline too. And so, for example, people with autism might have a deficit in one of these things, but that's their baseline, right? And then if they got sort of a fall in another one of these things, then we might start to worry, like, okay, is there also like a neurocognitive or a dementia process happening here? Right? And so what's normal and what's not normal? Because some changes we see are very common and are normal as we age. So what stays the same? Well, so like a lot of times your social skills stays the same, your vocabulary, the experience that you bring with you stays the same, right? Your intelligence stays the same. But what starts to decline and what's normal is processing speed. So sometimes it just takes people a little bit longer to pull out that information. People tell me all the time, like, I remember that name of the thing, but it just took me extra time. And I go, okay, that's great. That's normal. One of my geriatric psychiatrists here, wonderful guy, one of the godfathers of geriatric psychiatry, we're sitting in conference, and I tell all the new trainees, like, he's going to say something brilliant. It's going to be uncomfortable because he's going to pause. And you're going to want to say something. I'm like, don't say anything. He's going to say something brilliant, right? It just takes him a little longer to get it out. And he always says something like incredible. So you just kind of have to know that with older adults and just enjoy it, right? But like I said, attention might be less efficient, right? Things like that. Those things are normal. But why is that happening? Well, a lot of things are changing. Receptor density is a little bit less. We won't go into it. But those things are normal, right? But what we start to worry is that sometimes we get into these kind of three broad categories. Is the subjective cognitive impairment? So I hear this from a lot of my older adults who are just fine. They're like, I feel like my brain isn't going as well as it has in the past, right? And you do testing, you do everything, they're fine. They're doing just fine. So we call it subjective cognitive impairment. And sometimes, that's true because they just don't feel like they did when they were 40. And I try to tell these patients all the time is you're not being fair to yourself. Why do you expect to function the same way 40 years ago, right? So go easy on yourself a little bit. Mild cognitive impairment is when you have a deficit in one of those domains, but you can still take care of yourself. You can still get your day-to-day functioning just fine. And then what goes into dementia, what used to be called dementia, now it's called major neurocognitive disorder. They're the same thing. We just like fancy words. Is when you actually have impairment in some of those domains and your functioning starts to slip, right? That's when we start to worry. Um, and so this is very common, unfortunately. And so your risk of converting into dementia doubles every 5 years after the age of 65, which is kind of a scary thing, right? Individuals over the age of 80, about 40% have some kind of like cognitive deficit to it. And this is projected to grow, right? And this is very, very costly in the healthcare industry. Um, so I could spend days talking about dementia and all the different subtypes. And actually, there's a lot more subtypes than these four. These are the big ones. It gets really, really into the weeds, and some of these actually have some subtypes to them. We won't talk about them, but so dementia is the umbrella, and Alzheimer's, vascular disease, Lewy body, and frontotemporal dementia, those are subtypes of dementia or major neurocognitive disorder. And if you are a betting person, I'll answer your question. I'll just finish it. Go back one. Sure thing. Okay. If you're a betting person and you had a guess, it's usually Alzheimer's, right? That's the most common thing. It's super duper prevalent. And so I tell my fellows, like, we play this game all the time. We're like, is it dementia or is it not dementia? If it's dementia, what type of it is? And what happens is at the beginning of it, like, you can tell the differences between the dementias, but the longer it goes, it's harder to tell the differences. They start to look very similar. So it can get very confusing. And so I'll just say a few words about Alzheimer's disease because it's the most common. And what the signature of Alzheimer's disease is, it's memory problems, right? And so what we normally see is like short-term memory is affected because if you go in your brain right here, right by your temple, you go straight in about like an inch or so, you'll hit your hippocampus. And the hippocampus is where we form memory. Oh, 10 minutes. All right. This is a lot more than I thought I had. I'm going to get through this. Excellent. Thank you for that. And so if you get the hippocampus, that is exquisitely sensitive to damage and stress and oxidative stress. So a lot of times what we see is memory starts to go first. And so what people might start to say is they just kind of forget that things happen. It's like you have the same conversation multiple times and you find yourself repeating yourself for that person. Maybe they start to misplace objects around, or they're getting lost, they're forgetting their medications, or they're getting lost in their neighborhood, like a place where they've lived for the past 40 years and they have no business getting lost to, right? And all of a sudden they just kind of forget their way and don't really know where they are. But what stays intact is I hear all the time, oh, but dad can remember what we did as kids, right? And to me, that makes sense because those memories, those kind of long-term memories, they've already been consolidated. They've already gone through the hippocampus, through the whole thing, and they get stored other places in the brain. It's just forming new memories, which is the problem, right? And I'll talk a little bit about, so what I see as, unfortunately, we still don't have any great treatments for Alzheimer's disease. But what I tend to see is the neuropsychiatric symptoms that go along with dementia or Alzheimer's disease, right? And 80, I think I had some other slide deck. I mean, it is like somewhere between 60 to 90% of patients with dementia at some point have some kind of behavioral issue along with them. And so some of these things, I'll show you on the next slide, it can be very non-specific, right? But it's a problem because who's it a problem for? It's a problem for the patient because they may be engaging in like not safe behaviors, bigger risk of falling, getting lost. But it's a big thing for the caregivers too. Oh, yeah, you had a question. Yeah, that's a great question. I get asked that question every day. And so it depends a little bit of kind of what phase they're in. So the people who are subjective cognitive impairment, mild cognitive impairment, or even early dementia, this is what I say to them. It's all about protecting your brain from further decline. Because the terrible thing about these disorders, they're neurodegenerative. By definition, they get worse. But we can try to slow it down and optimize the other parts of their brain. And so how do we do that, right? And I tell people like, okay, so that you use your brain for lots of other things. Physical activity, right? Keeping yourself cardiovascularly healthy as possible, because we know that vascular disease, the disease that you have in your heart, can also have in your brain, right? So we try to keep people physically healthy. We try to keep people socially healthy, because we know, again, social isolation, loneliness are also risk factors, right? For not just for depression, but for cognitive disease as well. Um, Treating anxiety, depression, the psychiatric symptoms. I pointed out bi-directional relationships. So we want to actually treat those comorbidities that might accelerate the disease. And then finally, it's just keeping your brain active, right? It's kind of how do you be engaged in something that is engaging and meaningful to you on a daily basis, right? Those really, the evidence is we've got those have the best evidence. It's not actually anything fancy or medication wise. It almost kind of seems too easy and like the things we should be doing anyways, but that's actually the best evidence that we've got. Yeah. 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 Absolutely. Yeah, absolutely. Yeah. So I've got 1 minute left, I've realized.
Can you just
And
repeat what the question was real quick?
the question was is how do we treat cognitive disorders really? Well, like what's the best treatment? What's the evidence we have for them? And the answer basically is we don't have any great medications. And it's just those things that I mentioned, right? Staying healthy, being active physically, mentally, treating all the comorbid, both physical and mental disorders. Seems simple. Yeah. Well, how about this? This is my last 30 seconds. I'm going to skip all the way to the end to. I had a lot left. Like I said, I'm a talker. To what can you do here? Moving the field. How do we move the ball, right? Because geriatric psychiatry, I'm sad to say, the section that I skipped, it's a little bit of a dying breed. Sometimes I am out there recruiting on my own, trying to convince people to go into geriatric psychiatry. So it can't just be me. This has got to be a team sport. And so some of the things that we're doing is trying to integrate into other care settings, go to where the patient is, right? Try to focus more on community-based interventions, really trying to do preventative care. Telehealth has really changed the game. And now I can treat people. It used to be I could only treat people in San Francisco because they had to be kind of well enough, physically well enough to come into the clinic, or they had to be in San Francisco where they could come in. Now I treat people, in Sonoma and places far away, right? And finally, we've got to expand our workforce because I can't do it myself. So we've got to train other people to how to spot it. And I'm part of the American Association for Geriatric Psychiatrists. This summer, they're launching a certificate program of like working with older adults. So we've got to just share the information. And so what you can do, just talk about it. Share this talk with anyone. If you know someone older, we know this intergenerational connectedness means a lot, right? Preventing social isolation, loneliness. That's kind of the underlying theme here. That really helps. So just being out there, looking out for each other, that's going to make a big difference, right? Okay, so I will end there, and I will give it back to yeah.
We're going to go ahead and have a Q&A. We're going to have a Q&A if all the speakers could go ahead and come on up. Feel free to ask anybody any questions right now. We'll focus mostly on Dr. Duong's presentation, but sometimes questions have answers that can be supplemented by other speakers. So Joy, you can go ahead and come on up here as well, next to Avanel. Yeah, go ahead. You're fine.
And for the folks on the stream, we're going to ask you to use the microphone, please. So if you have a question, go ahead and raise your hand. I'll run the mic over to you.
Thank you so much. All right, so a lot of information to cover. There are a lot of topics that we would love to hear more about, but we're going to go ahead and narrow down to a couple. I want to go ahead and start off. Are there any audience questions? Okay, we have one in the back there.
Are there natural dietary things that older adults can take to maintain their ability to recall short-term memory, like specifically either vitamins or herbs or food that we can feed them?
Question. There we go. I assume that question's coming to me. Okay. Yeah, it's a great question. And you know what I tell older adults? I mean, the best thing that you can do is maintain your health. So those same vitamins that you are going to take otherwise, we know a lot of those things are cofactors, right? Catecholamines, for neurotransmitters, for example, like older adults are told all the time to take vitamin D. You know what? That's actually a cofactor for serotonin synthesis as well, right? We know things like having enough B12 and thiamine in your diet are also neuroprotective. You need those things for lipid production, which is in your brain, right? So these are the same vitamins you'd be taking otherwise, right? Making sure that you are not anemic and you have enough like iron in your diet, things like that. So it's not anything groundbreaking. I mean, it almost seems like common sense, but these are real things, and the real things that your primary care doctor tells you to do, do them because they help.
I mean, I feel much better about the vitamins I'm taking. I like that answer. All right, we'll go ahead and give the mic back to the audience in just a second. I'm going to insert one question related to, oh, did you have a follow-up? Hold it. Speak into the mic, Kristen. And that's Kristen from Tenderloin Housing Clinic. You'll hear from her more later.
I just wanted to piggyback on that because another thing that you can do is puzzles, board games, word searches are really helpful. I don't know if you do crossword puzzles, but puzzles and board games are really engaging. Not only do they maintain your cognitive function and they're healthy for you, but it's better for your memory. It's better also like the hand-eye coordination. A lot of people, I have a senior building with Tenderloin Housing Clinic, and one thing that we do is bingo. And people don't understand that bingo, that's hand-eye coordination. That is paying attention to the people in front of you and the presenter and what they're saying. It's listening, it's looking, it's the hand-eye coordination. All of those things you got to maintain those as you age, not just that's for everybody, but especially for our seniors. It's super important. Like games are really underrated, and reading, audiobooking, radio, those are all things that can keep you engaged and keep you healthy longer.
Shout out for solitaire in the audience.
100%. I learned how to play also Texas Hold'em with my clients. I didn't know they taught me, but it's awesome. That decision making, that paying attention, your interpersonal skills, and really paying attention to the table. All of those things are super helpful.
Thank you. So Dr. Duong, I wanted to talk a little bit more about misdiagnoses. I remember when I first was starting my disability studies, graduate work, I was worried about underdiagnosis, and then misdiagnosis actually became the beast that we really need to talk about more. When it comes to UTIs, things like blood sugar spiking, it can actually, people think it's dementia. They think they're having an episode related to dementia, but that's actually not the case. I'd love for you to talk about those common misdiagnoses, and maybe what tests you can insist on if your loved one has these sudden changes that did not increase gradually. What tests might we want to look at?
I love that question because once again, I'm always telling my residents, use all the tools in your toolbox, because I think in geriatric psychiatry, and what you said was perfect, if there's a sudden change, because the difference between, I think, dementia and delirium, which I didn't mention, or some of these other disorders, is that time course. If something is kind of slow and progressive, all right, it's a little bit different if it's a sudden change. If it's a sudden change, I'm usually thinking, oh, something else happened. You mentioned UTI. That's like the first thing I start asking about. I ask a lot of people, surprisingly, as a psychiatrist, about their like urine and then bladder function and their bowel function, because it's actually really salient. So, I mean, every year I get this new group of residents, and they're like, oh my gosh, this patient, something's wrong. I'm like, did you check for a UTI? Can we order some urine? And then they go, oh, that's what it was. You look like a genius. I'm like, it wasn't that hard, but we should always be thinking about these things, right? And so there's actually, when you start, there's a workup that we do. It's usually you get urine, we're looking for UTIs, we're getting thyroid function, because if your thyroid, if it's too low or too high, can cause anxiety, can cause you just not to think very well. any kind of infection, like if you had a skin infection or pneumonia, people can get confused, right? They can get delirious. And then I kind of mentioned those vitamins too. Sometimes if you're really anemic, you're just kind of not thinking straight either. And you mentioned blood sugar. We had a patient who got referred to geriatric psychiatry, had these like uncontrolled sugars. They gave him a diagnosis of frontal temporal dementia, which is a very serious diagnosis. Yeah. And then his blood sugars got under control and he was himself again. And I went, congratulations, this never happens. You've never had dementia, right? So there are a lot of things, but I think as geriatric psychiatrists, and again, I think this is why people get a little scared from geriatric psychiatry. You have to be thinking about these things. And then you also have to be thinking about the drug-drug interactions that happen too. Yeah. Because sometimes older adults get put on a lot of medications and they don't always play nicely and they have interactions and people don't realize it. And something else happens and they may look, delirious or not cognitively with it either. So there are a ton of things.
I love you mentioning the drug interactions. I've seen that as well. And I always recommend if your doctors aren't on some sort of computer system where they can see everything, you bring that printout with the dosage and the frequency because it's apparently very easy, as I've observed, for there to be drug interactions that the GP would not have been able to flag otherwise.
Yeah.
So I love that.
My favorite families, they bring me that whole list and it's all like color coded and I go, ooh, thank you. Can I copy this, put this in the chart? So it's very easy to lose track of medications. I think, and sometimes the primary care physicians send me patients just to review the medications that they're on. And they'll say, Dr. Duong will look at your medications and tell us if there's any drug-drug interactions.
Yep.
Right?
I literally carry family members their list on my phone. Yeah. Because you never know when you're going to need them.
Thank you for that.
I love it. Yep.
I really value that.
I'm ready for an emergency. All right. Take one from the crowd.
I have a friend who is in her mid to late 70s and she believes marijuana is medicine because she was diagnosed by her psychiatrist with anxiety and depression. And she said that marijuana helps her relax. Do you think marijuana is good for a woman? She's a Caucasian woman around 70, between 75 and 77.
Yeah, that's a great question. I think the topic of marijuana and cannabis has gotten really popular in the last 10 years. I mean, since I became a geriatric psychiatrist, maybe a little bit before when I was practicing just general psychiatry. And, I think that's a function of this generation's a lot more comfortable with marijuana and cannabis than prior older adults. So the question comes up a lot more and I almost got really surprised. And so I'll give you my stock answer. I don't know your friend, so I can't say specifically what's right in her case. Everyone is individual. So I'll tell you about the studies are still not there. We still don't know enough about marijuana and cannabis to say one way or another. So I usually say to patients, I'll tell you what I know. You'll have to make this decision on your own. And I can't endorse any particular thing. So what we do know is that cannabis affects what we call these sort of nicotinic receptors that are involved in learning and memory. And so it does. So we do know if you're really trying to help your cognition, it's probably not going to help your cognition, right? Can it be helpful for sleep and other things? I think, like I said, there needs to be more evidence of it. And we also know that there are certain types, right? We know that the ones of THC, which tends to be more psychoactive, right, can also be called what we could say entheogenic, in terms meaning that for some people, not everyone, it can actually produce a lot of anxiety. And I've had a lot of patients who, I had someone who came in, they're like, help me with my anxiety. And I was like, let's cut back the cannabis first and then we'll see. And then she went, so I did not need that anti-anxiety medication after all, right? Whereas things like CBD tends to be kind of less entheogenic. But then again, people say like, well, I don't know if it works for me, right? So the evidence is still kind of out there. So it's hard for me to say one way or another because we don't have those high quality studies yet.
Thank you so much. I'll ask one more, and then we'll have time for one more from the audience, if we leave. Excuse me, if you have a question. We didn't talk much about the shortage of geriatric psychiatrists, and I know some of the solutions to a lack of MDs, nurse practitioners became more popular, things like that. Are geriatric psychologists similarly short in supply? Do you see them as a potential solution to getting more treatment options?
That's a great question. I would love more geriatric psychologists, like period. We need them because it's hard enough to see me. Having a geriatric psychologist to be able to treat some of this with appropriate age appropriate therapy is also really hard to find. I am super lucky that I'm at UCSF and I had a really wonderful geriatric psychologist. She left but found me her replacement. I'm super duper lucky. And I'm really lucky that I have a geriatric psychologist who's skilled enough to do neuropsychological testing for me. So if I do need a more definitive diagnosis of dementia, she can help me out with the testing. And I know the VA actually does a really great job of having programs of training geriatric psychologists. But it's, again, just like geriatric psychiatrists, it's not for everyone. I think it takes a very, well, I'm going to toot my own horn. It takes a very special person to really enjoy working with older adults. I think you just have to have that patience, not scare very easily, and you just kind of have to really love the population. So I think it is tough. And so if you could convince some people to go into that field, that would really help me out.
Love it. Any last questions in the audience? All right, I'll ask one more before we wrap up. Related to dementia, we talked a little bit about, I would love to hear a little bit around diagnosis of a specific type of dementia. So in my experience, sometimes you go to one doctor and they give you one type of dementia, another doctor, they give you a different. I know someone who had 4 different diagnoses. So why might that be the case, and how important is it to really narrow down what type of dementia it is in terms of treatment?
I love that question. And you could do a whole fellowship just on that question specifically. And that's why I gave everyone the shortcut of like, if you have to guess, 75% of it's going to be Alzheimer's. But it is hard. And there's a whole bunch of subtypes. And the reason why it's tough is up until like a few years ago when PET scans got a little bit better, the gold standard to definitively diagnose dementia was on autopsy, brain autopsy. And so, yeah, so it's kind of like you kind of have a good guess, but you don't really know until, post-mortem. And then the other thing is that a lot of times people don't bring in family members or the patient doesn't come in until they're a little bit more advanced in the disease. And so what happens is, and I say it's almost like a fingerprint, very, very early on, you almost have to know what those first symptoms are. The problem is that people don't always know when they start to slip, right? And because I almost say it's like cancer, because at the beginning, they have their own what's called neuropsychological profile, meaning that those cognitive domains all are a little bit different. And so it looks different for those different types of dementia. But as you progress and more parts of your brain get affected, right, it all starts to look the same and it gets undifferentiated. And so it kind of matters of like when the person comes in, what tests that they got run, and what it looks like. And so I could very understandably say how you might get 4 different diagnoses depending on what time point someone's getting diagnosed. And then some of them are just very subtle and just like this little thing is different. So you got this subtype versus that little thing is different. So people spend their whole careers trying to subtype dementias. Yeah,
I believe it.
And it's not exact.
Great, thank you. We have one question on the computer, and then we'll wrap with this section. Hold on online, we're just testing the mic real quick. Do you want to go ahead and say it, April, and I can repeat it? I will try to capture all of that. Often adults with cognitive or psychiatric issues do not qualify for medical treatment, but hospitalization, but there are safety concerns. What do you suggest in those cases?
Yeah, that is such a tough question. So these are the patients that come to see me. These are the patients who kind of failed a lot of things along the way and now are coming to see me because everyone doesn't know what to do. And these are the hardest cases because you get families who are just pleading for help. Someone is just out there and they're not safe, right? And so a lot of times it's we start with kind of caregiver training. That's sort of like step one. Caregiver training. How do you not antagonize somebody and how do you redirect someone? And the Alzheimer's Association actually has some great trainings available to people. Like you can call them as a doctor. I can almost like write a quote unquote prescription and refer them to. So so step one is a lot of caregiver training, right? And like, how do you deal with this? And in some things you could kind of say like, oh, that's really understandable. For example, I get calls from nursing homes all the time. They're like, so-and-so's aggressive when we bathe them. And if you think about it, not letting someone kind of touch you when you're undressed is an overlearned skill. And we have learned that in our entire lives. It's almost like a reflex now, right? And that's a hard thing to break, right? And so you kind of almost have to weigh your options like, well, how much is bathing today worth, right? Well, what can we do to make someone feel safe? And what I often say to people is, don't contradict people on facts. I see a lot of family members saying like, you already asked that question, or no, you're wrong. It's like, don't respond to the actual content, respond to the emotions of it. And that actually goes a lot further because it's kind of like what that person's really trying to tell you is that they're scared. They may no longer have the vocabulary or the ability to tell you that they're scared, but they're still conveying that emotion to you. So it's like maintaining eye contact, talking softly, trying to redirect them so they do feel safe, right? And that's going to be different for every person. And then there are a lot of kind of environmental things that we can do too, like people who are wandering, putting locks on their doors, putting like alarms on. And I think we had someone who we had to like track their credit cards or like confiscate their credit cards. So there are a lot of the top things to do are really just our behavioral things. We could spend a whole day talking about that. And it's usually when people come to see me, all of those things have failed, right? And then we need some kind of psychiatric or pharmacologic intervention. But the best way to start is learn how to respond to the emotion of it. So that's the best advice I could give for someone who's not a health trained professional.
Absolutely. And it's very hard being a caregiver. It's very hard being a family member, especially if you're not in the same household trying to observe these things and address them. So we can talk a little bit more about that later. But Alzheimer's Association also has support groups for caregivers and things like that I've heard have actually been quite helpful. So thank you so much. Panelists, you can go ahead and return to your seats.